Hey Robert, what's going on?
Hey. I've fixed my hair so I don't look like a hooligan anymore. So I'm excited to be here,
I almost
looking
didn't
like
recognize
myself
you.
again. Yeah, I know. Well, a lot of people have had that problem. I get on Zoom and everybody's like, "What? Who's that?"
Who is this guy? Well, it's good to see you. We have some people joining. Oh, my brother Sahel joined. Hey Sahel, how's it going? How's everything going in Washington?
It's good. It's actually beautiful out right now. It's been hot this past week. I think it's expected to get hot and humid again, but today was really nice. I went for a walk at 10 o'clock, so that was
Well,
pretty good. Yeah,
great.
and you're back in Tampa, right?
I am in Tampa. I'm in Tampa. I'm seeing patients virtually, and actually I'm seeing patients virtually in St. Pete, and they just love this virtual experience. We'll be talking more about it
Yeah.
in just a little bit. I think we're pretty good. We could probably get started.
Okay, yeah, I think we're good to go here. So, Faisal, because we're myth busting today, I think what we can do is I will kind of interview you because a lot of the myths I think are questions. A lot of times are fears that are physician generated. So,
Sure.
I think a lot of physicians who have been practicing medicine the same way for a long time, in person, sometimes doing house calls, sometimes just in our current system, having them come in person. Um, but now this virtual care thing has brought up this idea of like, can you practice medicine over a virtual care environment? Is that actually able to be done? And what does that do for the patient relationship? I think that's one of the biggest like telemedicine, virtual care, remote patient monitoring critiques is what does it do for the doctor patient relationship? And I think a lot of physicians have a lot of concerns about that. So what do you think about that?
Well, I think number one, it's important to remember as a country, we're a very young country. The average American's only 37 years old. Now, my world is a geriatric space. My average patient is 72 to 74 years old. And so the doctor patient relationship with people who are elderly with chronic medical conditions, I think it's much, much more important, especially when you're trying to stabilize health and then get them towards a path of wellness. Of course, the doctor patient relationship is important for people who are younger, but when I think about younger patients look at doctors sort of like health coaches. If you had a, if I would like to think of myself with my patients who are younger being more like this health coach doctor than being this doctor who's telling them, hey, you got to do this, you got to do that. More being like a coach to work with them. Now,
Hmm.
in with geriatric care with my elderly patients, like this morning, I established two new patients, and these two patients from this morning, they never had a video call before.
Hmm.
That was the first time having like a FaceTime or a video conference, and they're both elderly, and they'd never had that before, and they loved it. The first patient, at her dining room table,
Hmm.
and at first she was very formal, and just kind of awkward of seeing a doctor in her home like this.
Hmm.
And within a few minutes, suddenly she became very chummy, very friendly. And she started opening up and we started talking with each other. She got relaxed. Her husband walked in. She was like, oh, hey, I'm talking to the doctor. And, and once that relationship, because right now we're not seeing that relationship
Right.
in healthcare and in the fee-for-service system today.
Yeah.
Healthcare in America right now is very transactional.
Right.
It's not this relationship where you're working with someone, like the doctor's working with the patient to reach a goal that's
Yeah.
attainable, and then they make a plan to work towards that.
I think that's a really important point because when we're in a fee-for-service system, the length of time for appointments is very fixed in order to be profitable for a lot of healthcare organizations. So the critique that virtual care it ruins the patient relationship is almost null and void in a situation where you have a 15-minute visit with a patient and the physician's sitting there kind of just writing in the EMR, not giving the patient a full attention. But over virtual visit, you're almost forced to get more personal and to get more kind of patient focused. Is that correct to say
It
that?
it is so much more intimate
Hmm.
especially when you're addressing a chronic medical condition, and especially chronic medical conditions that are rooted in issues like hypertension and diabetes.
Hmm.
I mean, even you could even look into being with overweight and obesity as well. But
Hmm.
especially when I'm finding, especially just now, I'm really, really deep in virtual care and providing virtual care in the geriatric space. With hypertension and diabetes, so much of that is lifestyle driven.
Yeah.
I feel that a lot of the formalities that are there when a patient is sitting with you in the clinic, they're getting processed. There's a waiting room. There's they're getting height and weight, and there's a formal process of getting roomed into the whole space. When you just pop into their lives in their in their homes, in the comfort of their homes, something happens.
Yeah, and you for those cardiometabolic conditions like diabetes and hypertension, we know that a lot of the benefit, and clinically speaking, comes from sort of a lifestyle change that can be motivated by a coaching type relationship. And I think we know that in the primary care setting, that is a best practice, is to be able to, coach patients to change their behavior and to encourage both adherence to sort of a treatment plan, but also to lifestyle modifications. And so when you're able to get more focused on that instead of, oh, here's the new prescription I have to write and here's the new, forms you have to fill out and things like that during a virtual visit, then, I think that's a really interesting and novel concept that hasn't really been studied yet. We don't know. In certain circumstances, I guess what I'm getting to is that a virtual visit might be of higher or the same quality as an in-person visit. What do you think about that?
Well, I think especially when you're talking about looking into the causes of the causes.
Yeah.
And you're talking about prevention and early intervention, it's not a reactive space. You see, I think with the full risk model, again, remember, I live in the full risk model.
Yeah.
So in my world, I want to look into the causes of the causes. I had a conversation today. One of the patients from this morning, no kidding, he was at an alcohol treatment facility. Mm-hmm. He had his first new patient visit with me while on break outdoors at this alcohol treatment facility. Mm-hmm. And he brought up, we started, we got to know each other. We were talking with each other, and I asked him, I said, when was the last time that you had to go to the hospital? If you go to the hospital, what do you go to the hospital for? And he told me, he said, I struggle with homelessness. Mm-hmm. I struggle with homelessness, and I run out of my medications often. And so when I run out of my depression medications, I oftentimes end up in the emergency room, refill with the medications. I'm usually very anxious. I get Baker Act, and it's this whole long, drawn-out process because I ran out of my refills, or I ran out of my medication before the time, or I lost my medicine before it was officially time to get the refill.
Yeah.
Tragically with him, it's one of those medicines that you can get from Walmart for literally, the cash price is $10 for a 3-month supply.
Right.
And I'm just thinking $3 for a month's supply of the depression medicine, he's ending up going to the hospital for a completely avoidable emergency room visit.
Right. And I think that component of providing access to a healthcare professional such as yourself or to your primary care physician through this means where it's easier to communicate those types of things and get them solved if the problem arises. I mean, imagine a scenario where this patient is able to video chat with you and say, hey, I need my meds. I was about to go to the emergency department. Can you help solve that problem? You just saved the healthcare system and that healthcare facility, tens of thousands of dollars. And I mean, that's a pretty simple fix by just providing a new route for a patient to access your services. And so, I think the access component here is really, really important. And your experience at ChenMed, I think, really speaks to that because the patient population that you serve has historically had bad access to healthcare services or, may have a lot of sort of social components that prevent them from being able to access healthcare services. What do you think about that?
Well, we specifically go into the areas of most need. So we are specifically in the areas with the most vulnerable patient population. I mean, we'll target areas where literally there's a difference in life expectancy by 20 based living in. And oftentimes for many of these people, when I think about just access to care in general, my background, even prior to joining ChenMed, was from the community health center world. So in my community health center experience, a 15-minute car drive, for example, in the city of Tampa, when you're using public transportation, can literally take 2 to 3 hours on the bus. And with virtual care, you don't have to wait for any of that. They don't have to wait to go through all the process that it is the doctor. Whereas in the fee-for-service world, you just, it is a very transactional sort of system. Oh my gosh, I think I just lost Robert.
I'm back.
Hey there. Good.
Yeah,
That was pretty easy.
yeah, I think we lost connection, but I think I heard the rest of that. So we were talking about access just before I left, and so you guys at ChenMed, you focus very heavily on sort of a population that is historically underserved by medical services and have high rates of chronic conditions and have a lot of social factors that prevent adequate use of healthcare services, as well as people with food insecurity and housing insecurity, as we just discussed. So one of the things I really like about virtual care is that it's convenient, and not just convenient because it's just like Netflix that you can access. It's convenient for people who might be working multiple jobs, who have to juggle childcare, who don't have an hour for a round trip in-person visit for healthcare services. They have the ability to do this with you and do it 20 minutes in their living room when they have a few minutes between childcare or between jobs to be able to access healthcare services. And I think that that's something that's lost a lot of times in the discussion. And it's a health equity benefit if you have this type of service to patients. So I'd love to hear what you think about that.
Yeah, I mean, if we just talk about the patient who runs out of his depression medications or misplaces his depression medication because he struggles with homelessness. So oftentimes he carries around all his possessions, he can carry it on his person. So if he misplaces his medication, and then because of not having his medication, now this person really lacks the capacity to make proper informed decisions. No concept of going to the emergency room and it costing the system $10,000 to refill a $3 prescription, where he can now actually at the end of our visit, I told him every single patient at the end of the visit, I give them my cell phone number. I say, hey, call me for anything. If I don't answer the phone, text me. Shoot me a text, especially if they're running into a situation where you misplaced your medications, you can't find it. Many times people get their medications even stolen when you're talking about people who are in that world of being home insecure and they lose their medication. Just shoot me a text. And what a tragedy. I mean, actually the main medicine that he takes only costs $3 a month.
Yeah. So here's my last myth. I think we're coming up close here to our time we want to stick to. But, a lot of people say that telemedicine or virtual care, you can't touch the patient, so you can't actually do anything. So one of the critiques is losing that patient relationship, but the other one is like, I'm a physician, I have to touch my patient. What do you say to that?
I was that doctor. I was that doctor that I didn't like the digital blood pressure monitoring. For example, I like checking the blood pressure myself. I to really get an accurate blood pressure reading. I was that doctor who wanted to check the pulse myself and wait 15 seconds and times it by 4 and say, oh, your heart rate is this much. Now, I mean, this week has been amazing. I'm seeing both especially with the hypertensive and diabetic patients, with pretty cheap technology, are showing me, oh, doc, well, my fasting blood sugar readings today was this much. For the last week, it's been this much. For the last month, it's been this much. And I thought, okay, well, that's great. That's good to know. And the same with blood pressure. Yeah. I didn't need to know what the blood pressure was just at this exact moment in time. Yeah. My patients are like, oh, yeah, my blood pressure is running in the 130s, 140s, over 70s for the last week. For the last month, it's been running this month.
Patients are a lot smarter than the system gives them credit for. I mean, it takes a little bit of time, but once patients learn how to manage their stuff at home and take their own blood pressure and keep track of that, which is where remote patient monitoring, I think, is starting to come in and mix with virtual care. Yeah. Where you now have access to the data from patients that you would normally take in an in-person visit, and you can do this sort of interaction, which is accessible and convenient. So the one thing I like to say is in response to that myth that you can't touch the patient is, one, we are starting to be able to collect more data from patients in the home. There's a lot of home-based lab tests that can be sent out. That space is growing quite a bit. There's a lot of medical devices that are FDA approved for collecting this information that do so automatically. So they do it really well, and the data is very reliable for patients to generate that information. But the other thing I say is that, it's not going to replace in-person visits. You always need to have in-person visits for certain lab tests or certain services that need to happen more quickly. And then for certain more advanced tests that can't be done in the home or monitoring that can't be done in the home, patients are still going to have to go sort of in person. So what we're going to see going forward is a mix between the two. So certain services might be more effective and might be better to be done virtually, more efficiently and with better patient outcomes. And some things might obviously still need to remain in person. Like, you're not going to be able to do surgery when the patient's in the home.
Yeah, of course.
So those types of things are going to have to remain in person. But that's what I see going forward. What do you think about that?
I mean, when we're talking about prevention and early intervention and really being lifestyle coaches,
Mm-hmm.
Primary care being these lifestyle, we become the lifestyle coach doctors
Mm-hmm.
in the system. It doesn't replace anything. Actually, it offers an extension.
Yeah.
I like to think of what we're offering is like what we use our cell phones.
Yeah.
The cell phone hasn't replaced anything. It's just an extension of ourselves.
Yeah. Yeah.
Well, here, let's see here. We've got some comments here.
We have a question. Does your practice have a social worker to work with issues in terms of homelessness?
Of course, you can imagine. I mean, we have an entire team that just deals with not only homelessness in general, but with food insecurity, especially. But both go hand in hand. But especially food insecurity and even basic things like they'll come up that we'll find out during COVID our patients didn't have, especially the patients that needed adult diapers, where they'll let us know that, hey, we have run out, we can't afford to buy the adult diapers, or we can't afford to buy toilet paper, things like that, where we'll actually Uber that from the grocery store to the patient's homes. But you can imagine in our world, we need to look into the causes of the causes. We need to be focused on preventing a catastrophic situation.
Yeah. And when we think about the factors that affect health outcomes, a very small percentage of that is actually the medical care. A lot of the benefit comes from things like these social services and from ensuring people have adequate food and healthy food and adequate housing stability. And so those types of programs, especially for patient populations that are in Medicaid or might be dual eligible Medicare patients, that's the type of thing that has high value and can produce big benefits for patients that are often overlooked. So I'm thinking next week we might want to dig a little bit deeper into sort of the social components that can be affected via virtual care and in sort of a value-based payment system. What do you think about that?
I love that. Imagine addressing the social determinants of health in a virtual manner. I love it. I love it. Let's do it.
Okay, perfect.
All right, super. Well, thank you so much. This has been great.
Yeah,
we look forward to doing it again next week.
Yeah, absolutely. I think we've both been having fun with this, so let's keep it going. And we'll look to answer some more of those questions next week as we hop on the call.
Great, super. Well, thank you all for joining. We'll see you next time. Bye.